Well, thank you everybody for joining me. This is a new lecture that I put together that I'm actually really excited to present because I think it's going to open up some opportunities for people who use the Richie brace for things like adult acquired flat foot, but haven't really explored the potential for this challenging condition. Much of what I'm going to share with you is from my own almost 30 years of clinical experience with the Richie brace, treating patients with a variety of conditions. And I must say that treating these arthritic ankle and rear foot joints in patients who may not have had any other viable option um, with the Richie brace really proved to be one of the most rewarding aspects of clinical practice. And so I want to share the anecdotal evidence of this and also back it up with some good scientific evidence-based medicine. One thing that's really interesting, many of you know this and some of you may not, but when we compare to the hip and the knee, the ankle joint is quite unique in that osteoarthritis does not occur in the ankle due to simple wear and tear as it does in the hip and the knee. It is almost entirely due to post-traumatic osteoarthritis. Um, it, um, it, it, it's kind of baffling why, and I'm going to show you in a few minutes. But the ankle joint, left alone without trauma, just doesn't wear out. Despite all the stress it takes in life, it actually behaves and functions very well. The knee is very prone to arthritis because of the large range of motion it goes through. And because there is a uniform loading through the medial compartment of the knee throughout life, that really puts a lot of stress focally on one part of the knee. We don't see that in the ankle. The ankle cartilage is a little different than that in the knee and the hip in terms of its biochemistry, which now is linked to how cartilage eventually breaks down from wear and tear. The ankle cartilage is less sensitive to the effects of cytokines, which have been implicated in the development of primary arthritis elsewhere in the body. So the ankle is a pretty good joint in terms of performance over time, as long as there isn't trauma. Now, the trauma, of course, can be either from ankle fracture, but even fracture of the calcaneus, obviously the talus. And as I'm about to show you, sprains of the lateral ligament complex are strongly linked to the development of osteoarthritis. Once we get arthritis in the ankle joint, we seem to get accompanied deformity. There's shifts of the talus within the ankle mortise, and that deformity itself is a real challenge in terms of bracing and even surgical correction. I want to focus on this relationship of the ankle sprain because this is clearly a preventable condition. I devoted a whole lecture on this, and you can find this on my website. I presented this lecture about a year ago about how evident it is now becoming that younger patients who suffer an ankle sprain are doomed to develop debilitating arthritis later in life. There's various papers on this, but let's just assume that almost half of all patients with osteoarthritis of their ankle have developed that condition because of an ankle sprain. And in fact, in many of these cases, at least 50% of the cases of ankle joint arthritis from an ankle sprain, it's due to one single lateral ankle sprain that occurred early in life. Studies have been around long enough for us to know that it takes about 50 to 60 years to develop end-stage post-traumatic osteoarthritis after a single lateral ankle sprain, which is not treated properly. And as I pointed out in my previous webinar, we're not treating ankle sprains properly if these poor patients go on later in life and develop debilitating arthritis. So it takes quite a while until the patients develop symptoms of osteoarthritis, but by then it's probably too late. A few years ago, the American College of Foot and Ankle Surgeons developed a very well thought, well researched, and well supported position statement on the diagnosis and treatment of ankle arthritis. And among their treatment recommendations that had strong foundation of scientific support was a recommendation that bracing the ankle with an ankle foot orthosis is effective in the conservative treatment of ankle arthritis. The rationale for bracing the arthritic ankle is to unload impingement and also to increase surface contact area across the ankle. Bracing will increase the external stability of the ankle, improving joint biomechanics, and the combination of all this hopefully will alleviate patient symptoms. If we can alleviate symptoms, we can delay the need for surgical intervention, particularly in those patients who are deemed unfit for surgery, either due to comorbidities or extenuating circumstances in their life, which prohibits them from having surgery in the near future. As I'm about to show you, bracing offers a very clear, rational, and acceptable alternative to maintain mobility for these patients until surgery is a more viable option. I'd like to share with you a lot of evidence that we've learned from offloading the arthritic knee. And sadly, there's not a lot of evidence of actually the biomechanics of offloading the ankle. But if we look at the way we've learned from offloading the knee, we can extrapolate and apply this science to the ankle. The two primary interventions for offloading, particularly the medial knee compartment, are these so-called offloading valgus torque braces, which we see in the top picture, or the use of laterally wedged insoles or lateral wedged foot orthoses. These two modalities work differently. The brace applies a torque or moment to the ankle joint directly. The wedge applied to the orthotic or the insole indirectly affects the knee joint by redirecting ground reaction force. As I'm going to show you later with the ankle, we can use both these mechanisms favorably with the Richie brace. Osteoarthritis affects primarily the medial knee compartment. And with bracing, we want to decompress or open up that knee compartment, as we see from the left-hand CT image to the right hand. There's been really good accumulated evidence of how these interventions work. And a number of systematic reviews of the accumulated research have been published in the literature over the past 10 years. What's a little bit a negative is the fact that these systematic reviews generally, in terms of lateral wedging, show very minimal improvements of symptoms and minimal biomechanical response of the knee to simple lateral wedging. All of these systematic reviews, as this one here, basically say that there's little evidence for overall improvement of knee biomechanics with simple lateral wedging. As this paper concludes with a systematic review, these findings do not support the use of lateral wedged arch support insoles for reducing knee load. One of the reasons this paper deduced is that the effect of lateral wedging is mostly taken up in the ankle, and the torque is not directed further proximal to the knee. So it's not to downplay the potential of lateral wedging in the ankle itself, as I'm about to show you. The other thing we've learned from this research on lateral wedging of the knee is that a lot of the research used only a heel wedge, as we see in the right-hand picture, whereas the favorable outcomes that we saw in some studies used a full-length wedge, lateral wedge from heel to sulcus or heel to toe. So this principle of using an extended lateral wedge, at least to the metatarsal heads, where we did actually see changes of eversion moment delivered all the way to the knee, is something that we can apply to AFO treatment of the arthritic ankle. Let's look at the biomechanics of actually bracing or offloading the medial knee compartment to decompress the arthritic joint. Valgus offloading knee braces, as compared to lateral wedge foot orthotics, do provides significant relief of pain, as evidenced in multiple studies and in this systematic review. The conclusion of this review of 31 studies of valgus knee bracing concluded that valgus offloader bracing is an effective treatment for improving pain secondary to medial compartment knee osteoarthritis. If that's true, how can we learn from this and apply these principles to the ankle? So basically what we're trying to do is offload or open up the medial side of the knee compartment, of the knee joint. And most of these offloader braces employ similar biomechanical principles. We basically want to apply a valgus torque to open up the medial knee compartment. And so this picture shows a right lower extremity facing us. And the first point of contact or pressure is point number 1. And that's the lateral femoral condyle, where the brace is pushing from lateral to medial above the knee joint. The counter pressure is applied distally with a lateral directed pressure against the tibia below the knee joint. So the principle here is that an adductory force is applied above the joint and an abductory force is applied below the joint to therefore apply or develop a valgus torque. And so we would, for example, use this same principle to apply a valgus torque in a varus deformed ankle joint. The other factor that we've learned specifically with ankles and with surgical realignment to decompress an arthritic ankle joint is the fact that we must take into account the entire alignment of the bones of the lower extremity, starting with the hip all the way down to the ankle. The pre-surgical planning for supramalleolar osteotomies mandates that we look at the alignment of the tibia relative to the talus and the ground, as well as the calcaneal alignment to the tibia, in order to plan the proper osteotomy realignment. This requires a full-length X-ray from the head of the femur carried out to the weight-bearing surface of the calcaneus and dropping a plumb line down to determine what is known as the mechanical axis passing through the ankle joint. It's interesting, when these X-rays are taken, we will often see that the area of impingement of the arthritic ankle is exactly where the mechanical axis is passing through that ankle. In this case, far too medial instead of centrally through the ankle mortise. We can see the profound effect of a supramalleolar osteotomy decompressing the medial aspect of this ankle joint and preserving the correction 5 years later. The principle of the supramalleolar osteotomy is actually somewhat embodied in how we would use the Richie brace to realign the tibia relative to the talus and the calcaneus and decompress the joint. In the end, we're trying to redirect or realign the ankle joint axis to move from the medial impingement point laterally or more centrally through the ankle joint itself. Keep in mind that when we look at these varus or valgus deformities in the ankle joint, it's easy to conclude, for example, that this left extremity has a adult-acquired flat foot deformity leading to end-stage valgus rotation of the talus. But not everybody with an adult-acquired flat foot develops a valgus deformity in the ankle. Some patients actually develop, as we see in this report, a varus rotation of the talus within the ankle, even though they have severe hindfoot valgus. In some cases, the calcaneus rotates so severely, it actually pivots the talus more into a varus alignment than valgus alignment. And so not all flat feet develop valgus rotated talus. And therefore, radiographic imaging of the ankle mortise is really critical before we do decision-making and prescription writing for ankle brace decompression. One thing I learned early in my clinical practice using bracing was not only taking an anterior posterior x-ray to look at the position of the talus and the area of impingement, but to actually simulate the effects of bracing with simple taping. We can apply taping, in this case, inverting the calcaneus to the ankle in the clinical setting, and have the patient walk up and down the clinic floor. And it is amazing how immediate feedback can be obtained from the patient with almost immediate relief of pain if you've selectively and appropriately either inverted the calcaneus or everted the calcaneus to decompress the ankle. The response to either varus taping or valgus taping will help direct your decision-making in the prescription for the Richie brace. So in this case, we're applying a valgus torque to the ankle and calcaneus to theoretically decompress a varus rotated talus. We want to test this theory by having the patient stand and walk for up to 5 minutes and see if they get adequate or at least perceived pain relief. And this can give you and the patient a lot of confidence that the brace is probably going to be effective. So when we're examining these patients, we take appropriate radiographs and we perform a physical examination and identify the location of their pain and where the impingement or where the pressure points are within the arthritic joint. We determine if there's either a frontal plane deformity or a sagittal plane deformity within the ankle joint. We can use the restricted hinge Richie brace to limit sagittal plane motion, and then we use enhancements within the Richie brace to correct frontal plane deformity and actually correct transverse plane rotational deformity. As I'm going to show you, we will use medial or lateral skives. We will use arch phalanges on the foot plate, which will redirect ground reaction force through the ankle joint. And then we will use the arch suspender to actually apply torque to the ankle joint. So we're really learning from the knee arthritis of the knee approaches, where we redirect ground reaction forces with wedging, and we apply bracing principles to actually apply torque to the ankle joint to correct varus or valgus deformity. So let's apply this now with probably the more common presentation of ankle arthritis accompanied with a valgus deformity in the talocrural joint. This is most commonly seen in the adult-acquired flat foot, stage 4, where the patient has suffered attenuation of the deep deltoid ligament. As the talus begins to rotate into valgus and the calcaneus everts significantly at the subtalar joint, these patients often present with pain in either the sinus tarsi or what's called subfibular impingement, the calcaneus itself actually abutting and pressurizing against the fibular malleolus. Adult-acquired flat foot, for some reason, almost always presents initially unilateral. And these patients, when we take radiographs, will show stark contrast of the symptomatic versus the asymptomatic ankle. The impingement here is clearly at the dome of the talus, as well as along the lateral gutter of the ankle joint. We confirm this with X-ray, but we may try an inversion taping, a J-strap applied under the calcaneus to invert the calcaneus and see if the patient gets any immediate relief, which is often quite compelling to do this and see how quickly just taping alone will decompress and give them moderate to significant relief on the spot. So we're basically trying to work with the biomechanics of the deformity and reverse all aspects. We can use the foot plate of the Richie brace to control abduction of the forefoot. We can use the heel cup to control calcaneal eversion. And we can use the brace itself to control tibial position over the calcaneus. We know that as adult-acquired flat foot progresses, the tibia shifts extreme medially over the calcaneus. This shift of the tibia medially is counteracted by pressure of the brace against the medial, the distal aspect of the tibia and the medial malleolus. So the patients present with lateral subfibular impingement, sinus tarsi pain. We want to try to move these bone segments away from each other to decompress both the subtalar joint and the ankle. So just like in the knee, where the offloader brace puts pressure against the femoral condyle, we're going to put pressure against the distal tibia and the medial malleolus and direct force laterally. Below the ankle joint, we're going to apply a varus torque. And I'm going to show you how we do this specifically with the Richie brace. So we've got a contact point here at the distal tibia, which the limb upright of the Richie brace, properly aligned, will effectively produce a abductory torque. And then we're going to use the foot plate of the Richie brace using a medial skive to not only invert the calcaneus beneath the weight-bearing surface of the calcaneus, but we're going to use the depth of this 35mm heel cup of the Richie brace to prevent abduction of the body of the calcaneus. So we've got multiple points of contact to realign this triplane deformity. It really starts with how we cast for the Richie brace. We recommend casting off weight bearing. That's a marked change of the way traditionally done in the O&P community with weight bearing casting for ankle foot orthoses. We have learned that if we can cast off weight bearing, we capture a more neutral alignment of the tibia over the calcaneus that will be preserved in the alignment of the brace itself, which will then prevent medial or lateral shift of the tibia with full weight bearing. As I will show you later, we mark the medial and lateral malleolus for our contact points and placement of the ankle joint hinge axis. Neutral suspension technique and the balancing of the foot orthotic portion of the Richie brace balances forefoot to rear foot deformity. And because we took this brace in an off weight bearing position, the alignment of the malleoli to the calcaneus itself is preserved in a more corrected attitude, such that when the patient bears weight and the tibia tries to shift medially, it's going to hit that brace and be resisted. Other forces, of course, will be directed against the body of the calcaneus inferiorly to prevent abduction and valgus rotation. The preferred brace for most of these arthritic conditions is the Richie brace with the restricted hinge pivot. This has multiple rivets placed at the ankle joint axis to hold the ankle joint at 90 degrees. Due to simple deformation of the plastic, there is some mild sagittal plane motion in this brace. It is not as rigid as a full solid AFO, but the good part of this is it allows some mild dorsiflexion during the stance phase of gait to allow a more smooth transition through the stance phase and prevent some of the negative effects of a full rigid solid AFO. We've learned from knee bracing that the ability to adjust straps and pull the brace tightly against the anatomy helps control transverse plane and frontal plane rotational forces. The ability for us to cinch the uprights tightly against the distal tibia and fibula further prevents the frontal plane shift of the tibia over the talus in arthritic conditions and arthritic deformity. This is something you cannot achieve with a rigid gauntlet. You cannot adjust this medial to lateral dimension on a day-to-day basis and tighten the uprights as tight as possible in order to control frontal plane shift. So we want to control this shift of the tibia medially over the calcaneus and control eversion of the calcaneus relative to the talus. So the shift of the tibia is controlled with the adjustable limb uprights. The calcaneal or rear foot position is controlled by the foot plate of the Richie brace, as well as proper footwear. The prescription criteria specific to the valgus ankle deformity in adult acquired flat foot is, as we stated, a neutral suspension cast where we reduce all forefoot supination deformity. I'll show you a picture of that a little bit later. We use the restricted hinge Richie brace with a medial arch suspender, which I'm about to show you. We use a medial heel skive to invert the calcaneus relative to the talus, and we apply a varus rear foot post to the rear foot portion of the foot plate of the Richie brace. And then I'm going to show you how a lateral foot plate flange will further supinate the foot and decompress the lateral aspect of the ankle joint impingement. The medial heel skive is well known to most of you. It imparts a varus wedge effect to the calcaneal weight-bearing surface within the orthotic foot plate. It was actually originally described by Marty Carlson back in the late 70s, where he showed how inverting the shape of the foot plate by skiving the plaster cast would create a varus wedge effect and shift ground reaction forces medially to supinate the rear foot complex and the ankle joint complex. To further enhance this, we have our patented medial arch suspender. This is an adjustable lifting strap to further invert the foot at the midfoot joints, particularly the talonavicular joint, to add varus torque to the ankle joint complex. This is an adjustable strap that can be applied either medial or lateral, depending on whether we're trying to decompress the medial or lateral aspect of the ankle joint. It is reimbursable with code L2275 as a varus valgus control enhancement to the Richie brace and to our Richie gauntlet braces. The patient is able to self-adjust and correct their pronation control as much as tolerated. It does tend to cause an abductory force on the midfoot, which is, therefore, in almost every case, we recommend applying a lateral flange on the foot plate to keep the forefoot from abducting. So this is the powerful enhancement for varus correction of a valgus rotated ankle joint. This is a patient with end stage 4 adult acquired flat foot with severe ankle valgus from a ruptured deltoid ligament, where we have effectively decompressed the ankle joint and restored at least 50% improvement of alignment with the restricted hinge pivot and medial arch suspender enhancement. A patient with a more flexible stage 3 adult acquired flat foot deformity, again with the exact same brace, restricted hinge, and medial arch suspender. We often find that when we're decompressing joints in the ankle and subtalar joint, that it's helpful, if we're not getting enough pain relief, to actually experiment with additional varus or valgus wedging on the top surface of the orthotic foot plate. If the patient's getting, say, 50% relief of ankle joint impingement laterally, we may want to add a little more medial wedge on the top surface of the foot plate after the brace has been dispensed, and in an attempt to try to further add inversion torque to the ankle joint. Flanges, as I mentioned, can be used to enhance supination torque to the ankle joint, particularly for adult acquired flat foot. Flanges really remain very misunderstood, particularly in the podiatry community, because most of us were trained that the high medial flange was an excellent way to control flat foot deformity. But we've actually learned that in some cases, a medial flange can cause the foot to pronate more, because what a medial flange will do is create a ramp or a platform tilted in such a way that it directs the foot to slide laterally off the orthotic. A lateral flange actually prevents abduction of the forefoot. which is what pronation of the foot really is. It's a triplane movement. And in adult acquired flat foot, abduction is a severe part of the deformity. So when we look at this right foot, adult acquired flat foot, the abduction is best resisted with a wall or a lateral flange, which pushes the forefoot medially. So we use a lateral flange to block forefoot abduction. A lateral flange acts like a wall, stopping lateral displacement of the foot. A medial flange works the opposite. It tends to prevent forefoot or foot adduction or medial displacement. So a lateral flange really tends to adduct the forefoot and actually reciprocally supinate the rear foot. Medial flanges have the opposite effect. They tend to pronate the foot. So we would use a medial flange more for a cavus foot or a varus deformity, and a lateral flange more for a abducted adult acquired flat foot. As I'm going to show you for the varus deformities, we tend to use medial flanges on the foot plate. And for pes planus and adult acquired flat foot, we use a lateral flange extended all the way to the fifth metatarsal head. So this is what a lateral flange may look like on a right foot Richie brace. Here's a patient with significant forefoot abduction. And with the Richie brace and the flange, we can see the significant transverse plane improvement, which will reciprocally decompress the lateral impingement of the ankle joint. So this is a real positive enhancement along with the medial heel skive, as well as the appropriate tightening of the uprights of the Richie brace to prevent displacement of the tibia over the talus. Posting can be somewhat effective with AFO treatment, but keep in mind that when we apply a post to the inferior surface of an AFO brace, it tilts the entire brace, including the tibia portion. And that creates conflict with a tibia that may be aligned properly to vertical. So unlike foot orthoses, where we don't really mind tilting the orthotic into extreme varus or valgus, we can't tilt an AFO in extreme varus or valgus without compromising fit of the overlying tibia. We do like adding wedges in the forefoot only, particularly out underneath the sulcus, because this imparts a pronation or supination control during heel rise and push off. And so we like using these valgus and varus sulcus wedges in certain conditions where we're really trying to control the foot through late mid stance and push off. I like valgus wedges, particularly when we're dealing with varus ankle deformity. Unlike valgus ankle deformity, varus ankles are much harder to control with bracing and with foot orthotic therapy. The treatments I showed you previously for the valgus ankle are almost predictable in terms of getting some success and some relief of pain in most patients. But the patients like this who present with varus deformity, varus impingement at the medial gutter of the ankle joint, for some reason are much harder to control. But we still have success, and we really employ some of the similar principles I just talked to you about previously. The varus ankle is interesting because it's very clear that in this case, the fibula and tibia are shifting lateral. In the adult acquired flat foot, they're shifting medial. So the lateral contact is what's going to be critical for the brace, and the medial contact and control of inversion of the calcaneus is also critical. The more the rear foot inverts, the more the fibula and the tibia displace laterally, and this lateral displacement must be resisted by the contours and the adjustable strap of the Richie brace. So we want to apply an adduction torque against the distal aspect of the tibia, or I'm sorry, of the fibula. This is a key contact point. And then beneath the calcaneus, We want to try to evert that calcaneus maximally on the talus. So again, we take a neutral suspension cast, which captures the alignment of the tibia over the talus and will then prevent lateral shift. We want to capture the forefoot valgus deformity that shows up in almost all of these varus hindfoot. The hindfoot varus almost always has a forefoot valgus, and that forefoot valgus must be balanced out in order to prevent compensatory inversion of the rear foot. We use the restricted hinge Richie brace with the lateral arch suspender. We use a lateral heel skive instead of medial heel skive, and we use an extended lateral flat valgus rear foot post. And in this case, just the opposite of the flat foot, we use a medial foot plate flange to try to put an abductory force on the midfoot and forefoot. So in this case, we use a lateral skive to evert the calcaneus. This is all done on the Richie brace prescription form. We will add a valgus sulcus wedge to abduct and pronate the forefoot on the rear foot. And in some cases, add a medial flange to the foot plate to further abduct or pronate the forefoot on the rear foot. So this is a difficult case of a varus deformity with a post-traumatic osteoarthritis that developed in a relatively young patient after a neglected syndesmosis sprain. This high ankle sprain led to widening of the syndesmosis, rotation of the talus into extreme varus, and the resultant impingement dorsally and medially caused erosion of the cartilage and pain and deformity at the medial aspect of the talocrural joint. Now, most of these patients will exhibit a forefoot valgus deformity. And one of the advantages of a Richie brace over most traditional AFOs is we employ podiatric principles in balancing forefoot to rear foot deformities intrinsically, just as we do with traditional functional foot orthoses. We apply balancing platforms such that this inverted calcaneus from a forefoot valgus is balanced to neutral or to perpendicular. So the balancing of the foot plate will already correct a lot of the varus deformity of alignment of the calcaneus and impart a valgus torque to the rear foot and ankle joint complex. The intrinsic forefoot post will support a forefoot valgus deformity and pronate the forefoot on the rear foot for valgus torque. So a patient like this with a cavus deformity who is not standing on a pair of balanced functional foot orthoses, when the forefoot posting is employed, we can correct the rear foot alignment by appropriate balancing of the forefoot valgus deformity, a powerful way to decompress impingement if it's present in a varus rotated ankle joint deformity. The ideal solution, therefore, is combining what we've learned about the fibular malleolus control with the correction of alignment of the rear foot, which we can now do with a Richie brace approach. By now, you've learned that with lateral impingement of the talus, we try to use medial wedging beneath the calcaneus. When we have medial or varus impingement of the talus, we use lateral skive, lateral wedging. So here's that patient, neglected syndesmosis sprain, varus deformity of the ankle. This patient presented to me several years ago at age 48 years, who has been given a proposal for an ankle joint fusion, which he is resisting doing because he likes to maintain activities, including walking a golf course. So the deformity is on the left ankle. And you can see that it's already now rotated into severe varus. And one thing that was interesting, when he came to me, he said he had found the Richie brace on a website. And he said that he thought the Richie brace could help him because he had applied a lace-up ankle brace to his own ankle and then used duct tape. And he showed me how he taped over the figure-of-8 brace. And what he basically was doing with the duct tape was everting the calcaneus as far as he could. So he was taping his ankle with a off-the-shelf lace-up brace. And when he pulled his ankle joint into severe eversion, he got significant relief. And once he told me that, I knew that our lateral arch suspender could accomplish every bit that, if not more. So by applying torque laterally and more distally on the foot with our lateral arch suspender, we could do everything that the duct tape was doing, along with all the benefits of the Richie brace itself. So here is the picture of the lateral arch suspender. In this case, we applied a valgus sulcus wedge, a lateral heel skive, and a flat valgus rear foot post to do everything we can to move that foot out of varus and decompress the medial ankle joint. So as you remember from the x-ray, the patient's ankle was pretty ankylosed and fairly rigid. So we're not going to see a complete rectus alignment or correction with this bracing system, but we're going to see improvement. And what's more important here is that he felt immediate relief of pain. Although we didn't correct the alignment of the ankle to neutral, he had 80 to 90% relief of pain because of the torque we were applying to the ankle joint to decompress it. And this literally changed this patient's life. He no longer feared or even thought he would have to undergo an ankle fusion. He liked wearing his brace and his lace-up shoes day to day. And he sent me this wonderful letter with a picture a year or two later after he climbed Camelback Mountain in Phoenix, Arizona with his son after he graduated from college. So this is that gentleman with that really almost debilitating ankle and the x-ray I showed you earlier, who was able to climb a significant mountain wearing his Richie brace relatively pain-free. One thing we've learned about trying to correct the varus ankle deformity is that we have to take into account tibial alignment. If there's any degree of tibial varum, it will really get in the way of correcting the deformity with the Richie brace. So this patient with a varus ankle, a varus tibia, we have to ask the lab, if we measure any tibial varum over 5 degrees, we ask the lab to evert the orthotic foot plate on the inverted tibia. Otherwise, the ankle brace is going to be oriented to perpendicular, and the inverted attitude of the tibia will carry the foot into varus and preclude all of the enhancements we tried to make. So the bottom line is, if you see a lot of tibial varum, anything over 5 degrees, please mark that on the prescription form and we will realign the foot plate to compensate for the tibial varum deformity. A lot of patients with ankle arthritis also have accompanied subtalar joint arthritis. And we have found that the Richie brace is an excellent way to approach deformity and in both joints using the principles I previously described. We definitely want to apply all of the principles of balancing forefoot to rear foot deformity. And in this case, we apply an extended flat rear foot post to specifically try to neutralize or minimize frontal plane subtalar joint motion. Now for the sagittal plane. We will occasionally, it's not as common, but we will see patients with anterior ankle joint impingement via x-ray or posterior. And there's specific strategies for both. Now for anterior impingement of the ankle joint, it is obvious that we want to plantar flex the ankle to decompress the anterior aspect of the ankle joint mortise. In the old days, we used to call this osseous ankle joint equinus, and it was always treated with a heel lift. But a heel lift by itself doesn't necessarily plantar flex the tibia. As I showed you in a previous webinar when we talked about offloading the Achilles tendon with bracing, the same principle really comes down to how we offload the anterior aspect of the ankle joint. So we learned this from an interesting study in England where these heel wedges, which are really popular in rehabilitating Achilles tendon ruptures, are placed inside of a cam boot. And when we took x-rays of these patients in a cam boot with these specific types of heel wedges, in photograph D, we realized that the talus wasn't really plantar flexing. It was still almost at 90 degrees to the tibia, because what happens in these wedges is the forefoot plantar flexes on the rear foot and the ankle joint stays at 90 degrees. The ankle joint isn't really plantar flexing. So same thing happens with a short heel lift. You put a short heel lift in a shoe, it doesn't plantar flex the ankle. It might be a great way to treat a limb length discrepancy, but if your goal is to plantar flex the talus, a short heel lift will not accomplish this because the forefoot simply plantar flexes off of it. You have to have an extended lift from the heel to the metatarsals in order to plantar flex the talus. This was shown in a follow-up article published in Foot and Ankle Surgery, where the platform type heel lifts or short heel lifts keep the talus almost at 90 degrees, but a full wedge from heel to metatarsal head will adequately move the talus into plantar flexion or into equinus and will decompress the anterior aspect of the ankle joint. So we, of course, in the Richie brace have a custom foot orthotic footbed. And so when we apply lifts beneath the brace itself, we have contact from heel to metatarsals with the orthotic foot plate. So we know we're adequately plantar flexing the talus. So we can decompress the anterior aspect of the ankle joint with a tapered heel wedge, with a foot orthotic that goes from the heel to the metatarsals. And we can limit motion of the ankle joint by combining both of these with our AeroSpring carbon fiber brace system. So this would, in my opinion, be the best ideal situation to control sagittal plane motion of the ankle, either to control impingement anteriorly, in this case with a heel wedge or orthotic wedge, but combined with the carbon fiber AFO brace to control sagittal plane motion. We can use the fixed position Richie brace and position the ankle into equinus. You can have the lab plantar flex the foot plate. Keep in mind, if you plantar flex the foot plate into equinus and you rest that brace on the ground, the limb uprights are now oriented in posteriorly or into recurvatum, really, to the exact degree of equinus positioning the foot plate. Basically, if you want us to plantar flex the foot plate, we've got to apply a heel wedge underneath the brace itself, underneath the foot plate, in order to bring the limb uprights to perpendicular. Without the heel wedge, the limb uprights are going to fall back posteriorly, which is not going to be tolerated by the patient. So we can take a standard Richie brace, plantar flex the foot plate, but you've got to ask the lab to add a heel wedge necessary to bring the limb uprights to perpendicular. Posterior ankle joint impingement is very difficult. You can't really use heel wedging, or you don't use heel wedging to decompress this. In theory, you'd add forefoot wedging to dorsiflex the forefoot on the rear foot, but that doesn't work well for walking and certainly doesn't work well for shoe fit. So in this case, we're really going to look at immobilizing the ankle joint in the sagittal plane with a carbon fiber AeroSpring brace, or perhaps this is the one case where I do think a rigid gauntlet is desirable for offloading the posterior aspect of the talocrural joint. Keep in mind, we do make a rigid gauntlet. This can control sagittal plane motion very well. And we can add our arch suspender to the gauntlet medial or lateral, if there's deformity within the ankle joint mortise. None of the enhancements that I showed you earlier of skiving and posting can be used in a gauntlet. And so all of the enhancements that I spent most of this webinar discussing are really not applicable or can't be used effectively with gauntlets. But controlling sagittal plane motion can be done, particularly for posterior ankle joint impingement. I want to briefly talk about offloading the midfoot joints for arthritis. This is something that can be done very effectively, but it can be done with a Richie brace, again with a restricted hinge pivot. But I really think a better combination is with the carbon fiber brace, with our Aero spring system, using a custom foot orthotic to offload the midfoot joints combined with the biomechanical effects of a carbon fiber brace. We've learned a lot about the way carbon fiber braces control the foot and ankle through the various rockers of the stance phase of gait. But generally, these carbon fiber braces store energy and release energy during the gait cycle. And they do so much better and much more effectively than plastic AFOs. They reduce muscular loading on the gastroc soleus. They reduce loading in the Achilles, and they reduce loading across the midfoot joints. And therefore, they can greatly relieve the compressive forces and loading forces on the arthritic midfoot joints, and after a Lisfranc sprain or a midfoot sprain. So basically, the combination of the foot orthosis with the Aero spring carbon fiber brace is really, in my mind, the most effective way to reduce compressive forces across the midfoot joints when we're trying to alleviate the chronic pain of midfoot arthritis or during the rehabilitation from a serious midfoot sprain or Lisfranc sprain. The carbon fiber foot plate alone has been studied up in Canada by Benno Nig's group. And indeed, the loading of the foot plate and recoil definitely reduces loading across the medial longitudinal arch during terminal stance. So we know from biomechanical studies that we are offloading and decreasing load at the damaged midfoot joints. Finally, as I've said earlier, the casting or scanning process for the Richie brace is critical to get the benefits that I've described earlier in this webinar. The website for the Richie brace is full of videos and teaching materials on proper casting, either with plaster of Paris, the fiberglass STS casting sock, and now digital scanning. We have videos showing how to scan the patient either supine or prone, and we greatly emphasize the importance of positioning of the patient to reduce deformity. By reducing the deformity, we know that the brace will prevent deformity when the foot is loaded with weight bearing. Those medial and lateral shifts of the tibia will be resisted by the brace when it's fabricated over a model where the deformity has not taken place. The foot must be positioned properly. It cannot be left hanging in space. We cannot scan the foot without properly loading the foot, positioning the foot in subtalar neutral, and pronating the forefoot on the rear foot for stability. By doing so, we know we will get a proper fit of the brace and get the benefits that I described previously. In the case of adult acquired flat foot, we recommend plantar flexing the medial column, reducing all forefoot supinatus deformity so that we get a better fitting brace, particularly with adult acquired flat foot. So we will balance out the forefoot to rear foot deformities in the lab, correct alignment of the malleoli and the calcaneus to the ground. We will preserve the plantar contours of the foot because the cast is taken off weight bearing, or the scan is taken off weight bearing, preserving these critical contours that are necessary for the foot orthotic portion of the brace to control the foot and try to enhance this valgus and varus torque we're trying to apply with the brace. If the brace fits the foot and the foot fits the shoe, the brace will fit in the shoe. In many cases, a lace-up athletic shoe is ideal for the Richie brace, and it's very rare for the patient to have to increase shoe size. This is one distinct advantage of the Richie brace over rigid leather gauntlets, which always mandate at least an increase of a full shoe size. The ability of the brace to be worn in sport is another big advantage over more bulky, rigid, restrictive, solid AFOs. I thank you for your attention, and I hope that I've at least piqued your interest in this topic and expanding your use of Richie brace for challenging conditions of the rear foot and ankle. Keep in mind that all ordering information of the Richie brace, as well as reimbursement information, can be found on the Richie brace website. This is the list of distributors in the United States. I know I might have some of my colleagues in Australia logged in, and they, of course, use our excellent Australian partner, QOL Labs, located in Queensland, Australia. And in the United Kingdom, our excellent partner there is Firefly Orthotics. They are all available to give you additional information for pricing, ordering, shipping, etc. I thank you very much, and I'd like now to open up to Sarah to see if we have any questions. Sarah?
Absolutely. I am struggling to get my camera turned back on, but you can hear me, correct?
I can hear you.
Okay, Zoom has this. Oh, there, I'm back. Okay. It was saying it couldn't detect it, and I'm like, I'm hitting the button. So, all right. We actually don't have very many questions right now, so this is everybody's opportunity to rack your brains and start thinking about your burning issues. Obviously, the appropriate ones. So, we do have one though. What if there are no X-ray findings, just pain?
Yeah, I think, palpation, determining if the pain is medial or lateral in the ankle mortise, and then the simple diagnostic taping. Do a J strap under the calcaneus, evert it to full range and invert it, and see which, I hate to say it, but you're really seeing which one feels better. And it's amazing that it will predict usually where the impingement is without the need to take an X-ray.
All right. How do you handle same or similar if they have an OTC device?
If they have a what device?
OTC.
Yeah, so great question. And I did a whole lecture on same and similar, same or similar, and that's on the Richie Brace site. But obviously, the Richie brace is a different brace than an off-the-shelf lace-up ankle brace. So it is a different brace, but Medicare would consider that similar, which is frustrating because they're not similar at all. If the diagnosis is different, you can prescribe a same or similar brace based on a different medical necessity. And it requires you to adequately document that this is an entirely different medical condition, why it requires an entirely different brace based on your physical findings and the actual benefits of this new and different brace, and be prepared to appeal any denial of the brace based on same and similar, because if the medical condition is different or if it's changed, Medicare will or is obligated to cover that new brace based on medical necessity.
And I'm going to put the link to that webinar in the chat. So if you scroll down to the bottom of your screen where you see your chat tools, I will post a link to that same or similar webinar.
Thank you.
Absolutely. What if there is drop foot also?
Well, every one of the brace applications I showed here was our restricted hinge brace, which is a very good drop foot brace because it holds the ankle at 90 degrees during swing phase. So you would be simultaneously addressing the drop foot with the restricted hinge brace. Our dynamic assist brace is a better drop foot brace because it allows dorsiflexion during the stance phase of gait. The problem is it doesn't limit sagittal plane motion enough to relieve symptoms of ankle joint arthritis. So we're really killing two birds with one stone if you have a patient with combined drop foot deformity and arthritis of the ankle joint, using our restricted hinge brace combined with the medial or lateral arch suspender.
Okay. Those are all the questions so far. Come on, everybody. This is my favorite part. Oh, here we go. Yay. Thanks, Dr. Block. Do you also have a lecture on Genu Recurvatum?
Yeah, I
Can you
talk
tell me
about
how to
that.
pronounce that so I can try again?
Yeah, yeah, I don't have a specific lecture on genu recurvatum, but it is included in my one of my webinars. I talked about general applications of the Richie brace, including drop foot. That webinar was called Getting Started with the Richie brace. And Sarah can show you a link to that.
Yep, I will do that.
You know, the Richie brace will not necessarily control genu recurvatum. We know that we can somewhat correct recurvatum by reducing the equinus deformity with a heel lift and appropriate plantar flexion of the foot plate. But I showed you a video in that lecture of a patient with post-polio, and the really only way to truly control genu recurvatum is with a knee ankle foot orthosis, which is a very sophisticated lower extremity orthosis, best done by a qualified orthotist. But in more mild cases of recurvatum, if you address the equinus deformity in the ankle, you can give pretty good symptomatic relief and good stability in gait with a Richie brace.
All right, so I just shot that link into the chat. So if anybody needs the link, and obviously, and these are all again, if you just go to richiebrace.com and then go to education, the webinar section under there you'll see them all here. But you can do it however it works for you. And then there was a question here that was, when will this lecture be posted on the website? So I have a personal goal to have it done within the next 48 hours.
Great.
So yeah. And Dr. Richie, give me a little slap on the wrist if you catch me dragging my feet on that one.
Okay.
Sometimes I need a little kick in my booty, but at least it's a digital kick, so that's fine.
And then, and if any other questions come up, I think it's on the website too, but here's my email address, drichiejr@aol.com. I love getting questions from clinicians and fellow practitioners. Email me. I usually get back to you the same day. And if necessary, we even jump on a Zoom call or just a phone call. And so I'm here for you anytime. I love interacting with my colleagues. So that's there for you anytime. Please take advantage.